Hey everyone, welcome to part 3 of our presentation on opioids and chronic pain. In this part, we're going to be talking about, is there a better solution?
All right, so what Jason and I would like to propose to you is that physical therapy is a better solution than opioids for chronic pain. So on this next section, we will speak on what PT is and how we intervene both in chronic pain and in opioid abuse. If you ask 10 people what PT is, you're likely to get 10 to 12 different answers. According to our American Physical Therapy Association, PTs are movement experts who improve quality of life through prescribed exercise, hands-on care, and patient education. Our goal is to prescribe exercise from an evidence-based lens in order to give our patients the best standard of care. Our goals are to help avoid surgery and prescription drugs, maximize mobility, manage pain and chronic conditions, and improve physical function and fitness. So how can PT intervene in chronic pain? There's been a lot of research in the last decade looking at what we can do for this patient population. Earlier, Jason spoke on some different types of pain and their mechanisms. A 2018 article in the Physical Therapy Journal outlines a mechanism-based approach for PT management of chronic pain. Our goal is to identify the primary mechanism or mechanisms of people's pain and tailor that treatment accordingly. The next few slides will present how different interventions help our patients in different ways. As mentioned previously, PTs are prescribers of exercise, and this is a very important aspect of our care of chronic pain. The type of exercise and the benefits it provides is dependent on the mechanism behind it. For nociceptive pain, exercise can reduce nociceptor activity. It can also improve healing of injured tissues in both nociceptive and neuropathic types of pain. For nociplastic or central mechanisms of pain, exercise can help reduce or even prevent the development of chronic pain. Exercise promotes analgesia through activation of descending inhibitory pathways and can modulate pain sensitivity by altering central processing that causes a pain response. Lastly, in patients with psychosocial pain, exercise improves a number of negative psychological factors, including catastrophizing, depression, and cognitive dysfunction. Exercise also improves learning, memory, and neurogenesis. Next, another aspect of our care is manual therapy. Research for the benefits of therapy has shown the greatest benefits for people with nociceptive and nociplastic pain. For nociceptive pain, joint manipulation activates peripheral analgesic systems in the body, reduces inflammation, and restores regular movement of joint and connective tissue, which may reduce mechanical activation of the nociceptor. For nociplastic pain, joint mobilizations increase serotonin, noradrenaline, and adenosine, and cannabinoid receptor activation, leading to analgesia. Manual therapy techniques are available to activate central inhibitory mechanisms, leading to decreased pain and central excitation. Lastly, an important aspect of PT therapy is education. In nociplastic pain, patients need education on what causes their pain and have their maladaptive patterns and behaviors changed. A study done using Lorimer Moseley's Explain Pain material resulted in central inhibition and an increase in pain thresholds in patients with chronic pain. For neuropathic pain, education is aimed at challenging beliefs associated with fear, catastrophizing, and anxiety. Pain education in this population is able to reduce catastrophizing and negative pain cognitions. And now for the PT's role in opioid abuse. Firstly, we need to educate patients on the risk of opioid medication and the benefits of physical therapy as a non-pharmaceutical alternative. An important way to get this knowledge across to patients is to make sure their providers are aware of the benefits of PT as well. A study done in Spine Journal 2017 estimates that 170 million people who went to their PCP for treatment of low back pain over a 13-year span only had 10% of these individuals receive a PT referral, while 45% had an opioid prescription. And this number needs to change. A 2021 article from the Substance Abuse Journal speaks on a larger and more aggressive role for PTs that they should have within the opioid crisis. Beyond just prevention, PTs can be useful in monitoring opioid use in patients who have a prescription and screening for opioid abuse in patients. Because we see patients one-on-one for an extended period of time, we have the unique position of seeing these patients through an episode of opioid use and can be a watchful eye on looking for signs of abuse. So what is the evidence? Multiple studies have shown that PT is associated with decreased risk of long-term opioid use. Early PT specifically has resulted in decreased costs, decreased work time missed, as well as a decrease in recurrence of chronic pain. A study done in Annals of Internal Medicine in 2020 reports that PT within 30 days of injury showed a significant reduction in opioid use for patients with shoulder, neck, and knee chronic pain. Overall, physical therapy has proven to be beneficial in patients who suffer from chronic pain and opioid misuse.
So now I kind of want to talk about what makes physical therapists so good at kind of intervening in this crisis. Physical therapists are well positioned to monitor patients throughout an episode of care to ensure that as a patient's function and symptoms improve, there's a concomitant decrease in opioid use if this is an intended outcome. PTs are more liable to see a patient multiple times over a period of a week and multiple weeks in a row over potentially months at a time over their course of care. Which is part of the reason that they're in such an optimal position to help patients who are trying to taper off opioids or trying to treat their chronic pain. However, limitations in direct access, including the need for a PT referral to have an insurance claim across many states, still limit the chronic pain patient's ability to access physical therapy. The adjustment to the physical therapist as a primary treatment option for the chronic pain patient is an institutional level undertaking that must start with a transition away from opioid prescription for chronic pain and into an increase in referral of physical therapy, either concurrently with opioid use in order to ensure proper usage, to monitor signs of abuse, and to ensure an eventual tapering of said opioids, or physical therapy as a replacement for opioid prescription altogether. The cost of opioid prescription in the short term remains low in terms of Medicare reimbursement. However, once pain transitions into the chronic phase, the direct cost of opioids skyrocket. There must be a push for more insurance coverage of PT referral to avoid overutilizing cheap, but less effective and potentially harmful forms of treatment. Additionally, lower socioeconomic status correlates with insurance plans that are less likely to cover PT referral initially, resulting in increased health inequity and leaving already vulnerable populations subject to suboptimal care. This is a problem that starts with the insurance and physicians and the healthcare system overall. Checks and balances need to be put in place in order to ensure all patients receive the same optimal care for the same conditions, rather than taking the cheap way out.
So what's the bottom line? We hope that our presentation today has given ample evidence that although opioids can be beneficial for short-term use, the consequences far outweigh the benefits in the long term. Physical therapy provides positive outcomes for chronic pain, decreased use of opioids, and can help reduce exorbitant healthcare costs spent on chronic pain and opioid therapy. So, when writing your prescription for patients with chronic pain, choose PT. Thank you all so much for coming to our presentation and listening in. If you have any questions, we put our emails in the description. We would love to hear from you.
Thanks for listening, everyone.